This is Soundcheck, your go-to podcast for ultrasound quality assurance, image review, and clinical education from MedStar emergency physicians. We walk through real cases, highlight what to look for, and dig into how ultrasound guides decision-making. Here's your host, Dr. Jon Watson.
Welcome back to Soundcheck, the case-based emergency ultrasound podcast where we review real ultrasound cases and share pearls and tips for improvement along the way. Today, we're starting with an athlete with left upper quadrant pain and shoulder pain who arrives pale, diaphoretic, and hypotensive with systolics in the 60s. Within minutes, though, the fast exam gives an answer and completely changes the next move. And that's just case one. We're also breaking down a post-cath risk complication where color Doppler shows the classic yin-yang sign of a pseudoaneurysm, a first-trimester patient with severe nausea vomiting where ultrasound reveals twins, a complex cardiopulmonary patient where bedside echo and lung ultrasound point to acute decompensated heart failure, and an ocular ultrasound case that helps identify a macula-off retinal detachment. Then we'll finish with a listener Q&A on getting better aorta images and practical techniques you can use on your next shift. As always, I'm joined today by one of my excellent co-hosts from the MedStar Georgetown and Washington Hospital Center Emergency Medicine Residency. This month we have Dr. Cierra Lewis, one of our senior residents. Dr. Lewis, thanks so much for co-hosting with me.
Thanks for having me, Dr. Watson. Always a pleasure.
No problem. So I'm glad that you're here. Are you ready to get into these cases?
Yeah, let's do it.
Case one came to the emergency department after he was at lacrosse practice, and he complained of left upper quadrant pain and left shoulder pain. So he said during the course of the practice, he didn't really have any specific injury, right? But lacrosse players, they are often kind of beat up during practice, and he had some pain after the practice and then came in for assessment. But he looked pretty sick on arrival. He was pale and diaphoretic, near syncopal, felt like his vision was closing in on him. And his blood pressure was 68/40.
Oof.
And so we were concerned for some sort of shock, of course, and concerned for possible hemorrhage. So with the abdominal pain, they did this study that we see here. So can you walk us through the views that we're seeing here, what exam they're likely doing?
Yeah, absolutely. So this is the right upper quadrant view of your fast, generally the first view we get. Goal is to kind of get an entire view of the liver, including Morrison's pouch with the kidney, but also scanning all the way through it up to the diaphragm, down to the tip of the liver. Here you can see the most superior aspect of it, which does have some blood pooling right up by the diaphragm.
Yeah, so this one's kind of subtle, right? You see a little bit, this is the diaphragm, this hyperechoic line coming through here. This, of course, is the liver. You see a trace amount of fluid here that's subdiaphragmatic, which is easily missed. But right here, we can't really see Morrison's pouch that you mentioned or the liver tip, so that's okay if I can't get it all in one view. We'll go to another one.
Yeah, so here's the typical Morrison's pouch view. You have the kidney there, and then it pans over to tip of the liver.
Yep, so Morrison's pouch here, and then liver tip, you said. Come down. What about the liver tip?
You see some blood there pooling by the tip of the liver, too.
Right, so all this anechoic fluid here, this is likely blood, right? Remember on a fast, we can never say it's actually blood, because the echo texture of blood and urine and ascites and all look very similar. But in the context of trauma and hypotension, it probably is. But there's been cases definitely where you have a acute bladder rupture where it causes similar findings. So just be aware of that.
And then another view of the liver tip, where you can see some of the bowel there within the fluid.
Yep, so loops of bowel right here. So positive right upper quadrant view.
Absolutely.
That's already enough to call it positive, right? We're going to walk through a lot more views, but right now you have a hypotensive patient, 68/40. He's got a positive fast. Next move is what?
Call surgery.
Yeah, trauma surgery. Try to get him to the OR if he's unstable. In this case, he did improve with some fluid resuscitation, and of course trauma was consulted, and this exam was done within 10 minutes of his arrival. So it just shows the importance of doing a fast exam for these unstable patients, and you can get the information very fast. You like that? All right. So now we're in the left upper quadrant. Walk us through the left upper quadrant. What sort of anatomy do we see there typically?
Yeah, so we're looking for the spleen and the kidney. They're coming together, which you can see in this case, the spleen kind of takes up the whole view of the left upper quadrant, and you're looking for
kidney here, but it's kind of in this shadow, unfortunately. So
looking around the spleen to make sure that there's no fluid around the diaphragm or the kidney itself.
So there's rib shadowing here, which is one of the challenges of the left upper quadrant view, right? You see them coming in and out of view and obscuring your field. But what else about the left upper quadrant makes it challenging to get?
Yeah, so the spleen and the kidneys, it's a little higher on the left side because it's not as big as the liver on the right. So you really need to go more posterior and superior when you're looking for these views in left upper quadrant.
Mm-hmm. Yep. So this is kind of what we teach as typical knuckles to the bed, right? Where you have your probe almost all in the stretcher because the area is more superior and posterior than the right upper quadrant. So as we look through, though, the spleen architecture itself looks a little funny here. So you see this, you could think that it's free fluid up here, but I think that the spleen body is actually like continuing up here, and this is all kind of within the spleen. So you have this anechoic stripe kind of going through the spleen itself, which I think would be concerning for a splenic laceration, which is what was the ultimate diagnosis in this patient. So we know the spleen is the most commonly injured abdominal organ in blunt trauma, right? So this would be a classic mechanism, even though he didn't have any specific injuries at high risk for it, unfortunately. Since lacrosse, they don't wear a lot of abdominal padding or anything like that.
Yeah.
All right, let's go. We're looking at the left upper quadrant still. Kind of seeing free fluid here as well. There's a trace amount there. And then some here as well, right?
Definitely important to scan all the way through for sure.
Mm-hmm. And then we're looking again at that abnormal architecture of the spleen, which I think this looks like a laceration of the spleen going through. Now what are we looking at?
Yeah, so this looks like an attempt at the pelvic views. They've labeled it bladder here, but can't exactly make out the specific structure of the bladder, but you do see quite a lot of free fluid. That the bowel is floating through there at the top, but largely just a huge pocket of blood.
Right. So this is a transverse view. So usually in this view, the bladder kind of has this rounded square appearance, right? So it's like usually in this shape, like that. But when it's outlining all the loops of the bowel like this is all just free fluid. This is not actually the bladder itself. So this is more of a pelvic view. I don't actually see the bladder when we're going through. It could be that the bladder is a pelvic organ, so a lot of people don't fan down far enough behind the pubic symphysis to see it sometimes, or maybe just peed, or since he's in hemorrhagic shock, he may have poor renal perfusion and not be making much urine, so that may be why as well. All right, and last view, just to round out our fast.
Yeah, absolutely, subxiphoid view. Just want to get a good look around the entire border of the heart. It doesn't look like there's any free fluid, so.
Yep, so no pericardial effusion, no tamponade. He would be having a very bad day with tamponade and hemorrhagic shock and hemoperitoneum. But so we talked in the case that he has shoulder pain as one of his presenting signs. So why do you think that he may have pain in his shoulder?
Yeah,
his shoulder was normal.
Yeah, when you have a lot of blood pooling underneath the diaphragm, you can have what's called Kerr's sign, which is essentially irritation of the diaphragm, which then refers up to the dermatomes of the diaphragm, C3, C4, C5. So that's why you can sometimes get that referred pain.
Yep, good. Yeah, so phrenic nerve, remember C3, 4, 5, keep the diaphragm alive, and that maps to the dermatome like around the shoulder, so they may have a shoulder pain incidentally as well. So the patient was fluid resuscitated. Trauma surgery, of course, was called right away after seeing this, and he did stabilize with the resuscitation in the ED, so was able to get other imaging. But like we talked about, if he's persistently hypotensive and unstable, this is an indication to just go straight to the operating room for laparotomy. But CT did demonstrate a splenic laceration. The patient was taken to the operating room. He had 1,200 milliliters of hemoperitoneum and had his spleen taken out, had his splenectomy, but ultimately did very well and was discharged about a day and a half after presentation.
That's awesome.
So next case, we have a woman in her mid-50s. She had a history of chronic heart failure who went to the cath lab about 2 weeks before her ED presentation. And she came to the ED because she was having progressive wrist pain, some hand weakness, and noted she was having some difficulty holding a fork and having some paresthesias in the hand as well. So The ED team had put a ultrasound probe on the patient's ulnar side of her right wrist, and they saw these findings. So what are we looking at here?
Yeah, so we're using our linear probe, and we're taking a view at the ulnar artery, which you can see kind of in the screen right lower section.
Yep, so this is the artery here. Okay.
And then it kind of drops down, and you see this large area of fluid/clot collection that develops kind of around it as you scan down the wrist.
Right. So it looks like there's a blood vessel, essentially, and a big growth coming off the side of the blood vessel, right? So
right.
Blood vessel here, and then this big, like, 1.5 centimeter circular structure there. So based on the case presentation and the history, what pathology would you be concerned about?
Yeah, so you're definitely worried about some sort of pseudoaneurysm that came off given the recent trip to the cath lab.
Yeah, that can cause enough vessel damage, and the high blood pressure from the ulnar artery can create this finding. So here again, you see the pulsatility. It's just another kind of view is similar, and it's a little bit of pulsatility up here at the end of the clip if you watch through. Right there. Mm-hmm. So it's hard to see. I mean, obviously you can see some pulsatility, but what's the next step that you should do to evaluate some vascular structures?
Yeah, you definitely want to put on color as a quick way to assess flow and rule out other sorts of pathology.
Good. So let's do color Doppler as well. So, right, we're going to put the color Doppler box over our area of interest. And here you're seeing the ulnar artery, but not much else, right? You don't see flow
Not yet.
elsewhere.
No.
Yeah. Not yet. Let's just remind everybody what the red and blue means.
Yeah, so red means flowing towards the probe, and then blue is speed or velocity away.
Right. Yep. So you can look at the key here to remind yourself if you forget that. I always remember the mnemonic BART, like Bart Simpson, blue away, red towards. But also the blue has a negative velocity. You could see the velocity here, negative 4.8 centimeters per second versus a positive velocity for the red, meaning that it's going towards the probe or away from the probe like that. So let's look then at the next view here.
Yeah, so here you start to see that there's also flow within this large mass-like structure, concerning that there's communication between the ulnar artery and this likely pseudoaneurysm.
Right, yeah. So if we're looking at our ulnar artery, right, the predominant color here is red, right? So there's a little bit of blue, artifact and stuff, but primarily red. What's the predominant color that we were seeing in the
Yeah, you largely see
pseudoaneurysm?
blue.
Yeah.
For
Blue and red, both,
Well,
right? Yeah. So we're seeing the hallmark of these pseudoaneurysms is you have this bidirectional flow, what's called the yin-yang sign right here. So this looks like the Chinese yin-yang, where you have blue going away from your probe and red going towards. So you have this bidirectional flow kind of swirling in this area of the pseudoaneurysm. It's connected to the actual artery here through this tiny neck, right? And then we don't see flow elsewhere, right? So all this is still part of the pseudoaneurysm, but why is there no flow here?
Yeah, so it's stagnated, likely blood at this point, causing a hematoma in the surrounding area, but no specific flow in those areas, which is why it doesn't show up on color.
So basically when you have recent radial or ulnar artery access, some swelling afterwards, one of the top things on your differential should be pseudoaneurysm. You're concerned that whenever you have skin entry or skin puncture that you have some sort of subcutaneous abscess, right? But this is probably not one that you'd want to IND.
Yeah,
right?
definitely not.
You
Always
would
check
have-
with color.
Yes, you would have a big mess on your hands if you tried to incise and drain this mass. So in this case, the vascular surgery was consulted and they admitted the patient for observation, but ultimately they did not do any major surgery to ligate this or anything like that. What they did actually was inject thrombin into the area to give some pro-coagulation factors there. And they held manual pressure, actually. It says in the note about for 30 minutes, they just held manual pressure just sitting at the bedside. And the size went down. It didn't expand anymore. They just observed it for a few days and then she went home. So these can be treated fairly minimally invasively as well. Next case we have is a woman who came in stating that by dates in her last menstrual period, she was about 9 weeks pregnant, but hadn't had any OB care quite yet, who came in with persistent nausea, vomiting, and basically unable to tolerate any oral intake. So she was prescribed some antiemetics and stuff, but she just wasn't doing well, so she came into the ED for evaluation. So as part of the workup, they did this scan. So walk us through, Sierra, what you're seeing on the scan.
Yeah, based off the footprint of the ultrasound probe at the top, you know this is a curvilinear probe as opposed to an intracavitary probe. So we're doing a transabdominal ultrasound, and you can see as we're fanning through, the uterus comes into view, and you see 2 areas of amniotic fluid with fetal parts.
Yep. So we see 2 basically gestational sacs here with some fetal parts inside. So she's got twins. So these images are a little hazy, right? So we will of course take some more, but what's one tip that you always want to tell the listeners that it went for success for transabdominal imaging?
Yeah, so when you're doing transabdominal, remember ultrasound probes travel best through fluid. So if you give her a little bit of fluid and have her bladder kind of come into view, you can sometimes get crisper images on the transabdominal probe.
Right, exactly. And that's contrary to if you were doing transvaginal imaging, you would want to make sure that they empty their bladder. But full bladder is definitely helpful because you can use the bladder as an acoustic window to get better images for transabdominal imaging. Sometimes you just don't really have an option. They just had peed, but if you can help it, just have them keep a full bladder. So next, I have another view of the transverse uterus, and flashing through here at the end, you have to focus your eyes here and here.
You can see some heartbeats.
Yep. So you see a little bit of fluttering there, consistent with the fetal heart rate. So now we have confirmed double IUP, right, with fetal heart rates. So we'll go through and take a few more clips. Same thing here.
They really should have decreased their depth, but whatever.
Yeah, that's a good point. You may be getting better images if you optimize for depth, right? Since all this is wasted space back here, we don't really care what's behind the uterus, right? So the general principles of ultrasound is you want to have your target organ in the center of the screen, right? That's where the resolution is the highest. So you could probably set the depth to 9 centimeters or something and have a much clearer image. And that may come into play a little bit later. So we still have the transverse uterus. They're just taking multiple views of it. We did see the heart rates. They're going to do longitudinal uterus as well. So you see those 2 in longitudinal view. Another transverse. I think they're trying to show the fetal heart rate again. If you focus here, you can see the heart rate right there. And then for the other one, can't see it super well, but they did do a fetal heart rate tracing as well. So when you have twins or multiple gestations, you have to differentiate them, right? Yeah. So if there's a problem with one, everybody's consistent on what they're referring to. So how do you differentiate the twins on ultrasound?
Yeah, great question. You actually label them twin A and twin B based off which twin will deliver first. So essentially which twin is closer to the cervix. So from a transabdominal view, it will be the more posterior or lower lying baby.
Yeah, so the one that's lower down here. So this one is going to be twin A. That is just so we're consistent in the different ultrasounds that we do. So now what are they doing here?
So now they're doing an M mode through the fetal heart tracing or the fluttering of the heart to get the fetal heart rate.
Right. So we're doing it on twin A here, and we use M mode to calculate the fetal heart rate rather than Doppler because it has lower energy associated with it than using the actual Doppler and getting the sound of the heart. Do you know about the principle of ALARA? Remember that? So there's this principle called ALARA, A-L-A-R-A, which means as low as reasonably achievable. So that means that we use the ultrasound settings and modalities that have the lowest thermal and mechanical index to get the information that we need. So Doppler uses more powerful waves that come through that create some heat within the tissues. So if you use the Doppler gate, you're theoretically can cause some tissue heating up that we want to avoid in a developing heart. So M-mode's an easier way that doesn't use additional energy to be able to trace the fetal heart rate. So we have the fetal heart rate there. We just look for a repeating pattern. It's not like, it doesn't project super well, but you would look basically like at the 5 centimeter mark here where we'd expect the fetal heart, and you look for a repeating pattern, and you see these like wavy things here. They're measuring something. I'm not like terribly confident about it, but we saw that there was fetal heart rate on the live 2D imaging. So now we're going to do some measurements.
Yeah, so this early in the pregnancy, you want to get a crown rump length.
Mm-hmm.
Earlier in pregnancy, the more reliable the dating is. So when you see patients at this early gestation, you want to get as good of a crown rump length as you can.
Yep.
And then you want to measure basically the entire fetal pole part. In this case, I think maybe is a little
mismeasured.
small. Yes,
Yeah.
a little small of a measurement.
So I think we're seeing things here, right? So this case would probably be a great candidate for a transvaginal ultrasound, right, where you can see more clearly. But I think this is probably one of the poles. So the measurement's probably here to here, and we'll see that because there's some discrepancy between twin A and twin B. So this is B. It's cut off here, but it's measuring 7 weeks and 4 days. So then if we go to twin A, they're measuring this dimension, which is cut off again, but it's 8 weeks and 4 days. So we have a 1 week difference between our twins, right? So that shouldn't happen, right, physiologically. I wouldn't be exactly sure what to tell the woman in this situation as far as the due date and things like that. Because, like you said, first trimester ultrasound is typically the most accurate in dating, but you want to make sure that your dating is really only as good as your measurements. So transvaginal would be good here, or just rotating the probe just to make sure that you're confident in getting the correct crown rump length. All in all, it probably doesn't matter too much for ED care, whether it's a handful of days off, but it just would be nice to be able to know. The important thing is we have identified that she's got intrauterine pregnancies, rule out ectopic, and then we can work on trying to treat the symptoms. So why do you think that she's having such bad nausea, vomiting, other than just being pregnant?
Yeah, so she, with the 2 gestational sacs, has a lot more beta-HCG floating around in her bloodstream, which correlates to severity of nausea. So when you see multiple twin or triplets or things like molar pregnancies, you have a lot of beta-HCG that can cause pretty severe symptoms.
This next person had a history of COPD, heart failure, hypertension, diabetes, came to the emergency department with chest pain and shortness of breath. So given his complex cardiopulmonary history, they did a bedside ultrasound to look for cardiac function, to try to get a gauge on the volume status, and look at the lungs as well. So we're going to do a echo here, an ED echo, as well as a lung study. So walk us through, Sierra, what you're seeing here on this first view. We have parasternal lung.
Yeah, so this is the first view of a bedside echo, the parasternal long axis, generally found right next to the sternum and intercostal space 4 or 5, depending on the patient.
Yep. And this is in the ED echo standard versus cardiology. Sometimes some of the viewers may see that this is reversed in some of the cardiology echoes, but we do ours with the probe marker on the left side of the screen here. So, like as you said, the indicator is pointed towards the patient's right shoulder this time.
Mm-hmm. Okay. Here you're looking essentially at in the middle of the screen you have the aortic outflow tract. The most superior ventricle that you see is the right ventricle.
Right ventricle here.
And then farthest away from the probe is the left atrium emptying into the left ventricle.
Yep. So blood's coming in here through the left atrium, which looks pretty big, right, if you look at echoes. And then it's coming through here, which is the mitral valve, right, through the LV, and then through you can see the aortic valve here as well, going up through the left ventricular outflow tract aorta.
Yeah, and what you notice is that the left ventricle is not squeezing very well.
Yeah.
It appears big and dilated, and you're concerned about poor EF in this situation.
Yeah. So we can try to get a gauge on the EF by just looking, right? You can just get a qualitative assessment about what the EF is. And, the reality in the emergency department is like, we're not really going to do anything different if the EF's like, 51 versus 54.5% or whatever, but you want to know, is it normal? Is it hyperdynamic? Is it a little bit reduced, or is it severely reduced? So what category of those is this patient?
This is significantly reduced.
Yeah.
Not really squeezing well at all.
Right. So gross hypokinesis of the LV. There's a couple other things that we can do besides just looking at it to assess what the squeeze is. So what about the mitral valve?
Yeah, so if you want to get more of a quantitative measurement, you can put your M mode through the mitral valve as it opens and closes and essentially measure how close it gets to the septum. And that's called endpoint septal separation,
Right.
which will, in a normal patient, you would like to see that the mitral valve opens and gets really close to the septum, and then as the heart ejects fluid, it closes, of course. But in severely reduced function, like this patient, you can see the mitral valve does not get at all close to the septum.
Right. So they didn't do EPSS in this case because I don't think it was necessary, but essentially you would put an M cursor here, like you said, just over the tip here, and then you get a nice tracing and measure the gap. We can sort of measure the gap here if we want. Let's see, let's put a caliper on. And we have like 3 centimeters of space, right? So that's not getting anywhere close. That's consistent with severe reduced ejection fraction. Greater than 14 millimeters or 0.14 centimeters will be in the severe range. So that's very high. All right, now we're on parasternal short, right? It's mislabeled. It still says parasternal long, but how did they get from parasternal long to parasternal short now?
Yeah, common mistake. I often forget to change my labels, but essentially you stay in the exact same location on the chest with the probe. However, you just twist it 90 degrees. So if you were in the parasternal long pointing towards the shoulder, you're now pointing towards the hip. And then you get this nice view of the right ventricle and left ventricle. The right ventricle is on the screen left, and then you see the donut of the left ventricle there.
Yep. So some people like to say a croissant and donut. So we have like a C shape, like crescent moon shaped right ventricle here, and the nice circular LV. How else do you think they could optimize this image?
Yeah, so I'd like to see a little bit less depth here. You want to get the ventricle in kind of the middle of the screen. It'll give you a better view, but also if you want to do any measurements or vibe check assessments of LV, it's a little bit better when you have a better view.
Yeah, right. So this is all sort of wasted space, and it's kind of helpful, I guess, in this scenario because we can actually see some effusion, which is like a pleural effusion. But in order to assess the LV or the heart hemodynamics and stuff, it's probably better to have it bigger. So overall, it just looks very hypokinetic, right? I don't see any specific wall motion abnormalities. It's just none of the walls are moving that great. But this is one view where you can put your cursor or your finger in the center of the LV cavity and look to see, like, is the inferior wall and the septal wall and the anterior and lateral wall all moving close, or, moving the same inward towards the cursor or your finger. It's a kind of quick and easy way to assess for wall motion abnormalities. So we'll move on to the next view.
Yeah, so this is your apical 4-chamber view. Often is difficult to find on patients, but move laterally towards near the axillary line of a patient, and then angle your probe up towards, like you're looking at the bottom, up. And then you should get this 4-chamber view. You have your left ventricle there on screen right, and then you're not getting all of the right ventricle on the left, but enough to see kind of the function of the left ventricle, which is still obviously very reduced. And then you want to see your atria at the bottom, which are very large still.
Yeah. You can see a little bit of tricuspid valve poking in and out here, mitral valve here. This is your aorta here on the other side of the heart.
And then your final view of the echo is your subxiphoid. You're looking at the essentially circumference to make sure there's no large effusion. Here you can still see grossly that the ejection fraction is very weak, but no pericardial effusion.
Okay, good. So then this is one of the ways that I like to transition to the IVC, which we'll see next. The technique I usually use is you center the right atrium on the screen, so I'd tilt my probe a little bit to bring this right into the center. And we know the IVC drains right into the right atrium. So I then bring my probe up to perpendicular to the patient's body, and then you rotate the probe 90 degrees and put the probe marker towards the patient's head, and then you'll see a view like this Again, we should probably decrease our depth because this is all not useful information back here. We'd really want to focus on the IVC. So now the head of the patient is up here, the feet down here. So we should have blood draining from the feet and abdomen and all that stuff up into here and to the right atrium. So what do you notice about this IVC?
When you're looking at an IVC, really you want to look and see if it's really collapsible or really large and distended. This one appears to be pretty large, just grossly looking at the measurements with the centimeters on the side. And then right kind of before you get to the heart, you see that the hepatic vein is coming in, which is a good way to distinguish between the IVC and the aorta.
Right.
And you can see that is also pretty dilated as well.
And then there's the blood vessels should be more or less anechoic, right? But you see in here like some swirling and some smoky haziness appearance. This is just due to kind of turbulent flow and sometimes some regurgitant flow from poor forward flow. So this is one of the also findings of volume overload and some turbulent flow there. So when we measure the IVC, you mentioned it could be big and dilated or small. We typically measure right around here. So why is this area significant?
Yeah, so you want to be just far enough away from the heart that you're not getting any regurgitant flow or increased pressures when you're measuring the size of the IVC. So about 2 centimeters away from that area is where you want to measure.
Yep, from where the hepatic vein comes in, about 2 centimeters distal or towards the feet, which is what they're doing here. And they got a measurement of 3.2. What does that tell you?
Yeah, that shows you that the IVC is pretty distended. Normal is about 2.1 centimeters, and you always want to measure that in expiration, where the IVC is going to be the largest, so you get the maximal diameter.
Mm-hmm.
So This just confirms what we were grossly seeing, which is a distended IVC.
Yep. So there's some other things that you can do that they didn't do in this case, but you can check the collapsibility index, like how much it collapses with inspiration, right? What about for an intubated patient? What kind of index do you do there?
Yeah, so when you're having a lot of positive pressure that you're giving the patient, either if they're intubated or they're on BiPAP, then you actually need to do the distensibility index, which is essentially the reverse measurement, but it's a percent change where you measure the maximal and minimal diameters, and that can also give you a estimate of pressures.
Yep, perfect. All right, so in general, these findings with a dilated IVC, very minimal respiratory variation, make us concerned that there may be elevated right atrial pressures. So we use this as a surrogate. And I think this is more helpful in the extremes, right? Like we talked about, if it's really big and not much respiratory variation, that tells you that's a very different patient from IVC that's very small at expiration and then collapses completely when you do like the sniff test if the walls of the IVC touch each other. So going along, now we're on the lung study.
Yeah, so we're still using the cardiac probe here. You can see approximately 2 centimeters down is the pleural line there. You see some good sliding, those little ants, but you also see some B lines kind of extending down below that, which is an indicator of pulmonary edema.
Yep. So B lines are indicative of fluid in the alveoli. So sometimes you can get that with like pneumonia and stuff too, just because you have fluid in the alveoli. But in this case, what we're going to see is it's diffuse and there's lots of B lines everywhere, which is more consistent with the global process like volume overload and pulmonary edema. So let's look here at the right anterior lung, again seeing that lung sliding, but you have lots of B lines here. So typically in order to diagnose pulmonary edema, it's got to be 3 or more per intercostal space and in multiple lung regions, right? So like I said, you can have B lines if you just have a focal pneumonia, say you have a right base pneumonia, you may see B lines in that one area, but you can also see things like sometimes air bronchograms and things like that. But if it's diffuse all over, that should make you concerned for pulmonary edema. Seeing more of the same here, those bright common tail artifacts called the B lines. And then walk us through this view here.
Yeah, so you're scanning down a little bit more posterior in this view. You can see the diaphragm kind of coming into view and then a pretty distinct area of anechoic region concerning for a pleural effusion.
Right. So this is fluid also, but fluid outside the lungs in the chest cavity. kind of third spacing in the chest cavity. So this is a pleural effusion here, kind of layering and falling down right by the diaphragm, which you see this hypercoque line here, over the liver here. And then you have, in addition, pulmonary edema within the lung tissue itself. So this patient has fluid everywhere. And kind of seeing the same thing here on the posterior lateral lung on the left. All right, so overall, what's your assessment of this patient? Why do you think he's so short of breath?
So I think he's actually having a CHF exacerbation. He's got a lot of fluid kind of throughout his lungs as well as effusions. I'd definitely be placing this patient on BiPAP.
Yep, so the afterload reduction, BiPAP, nitro, Lasix, some sort of diuretic, and likely admission to the hospital if he's in distress. Last case we have for today is a man in his 50s who came with some vision blurriness and seeing some shadows after he actually just rubbed his eyes, which is pretty scary. But he had very decreased vision on visual testing. So in his right eye, which we'll look at first, he had light perception only, which means that you can't even read the eye chart. You can't count fingers, you can't see hand motion. You can basically only perceive that there's light. And the left eye, his vision was 20/100 on the eye chart. So given his vision loss and the fact that we're not the best at fundoscopic exams in the emergency department, really simple, easy thing that we can do is eye ultrasound. So walk us through, Sierra, how to do the eye ultrasound and the findings that we're seeing here.
Yeah, so I like to do, I think it's quick and easy. Setup is important though, because a lot of times you need a good amount of gel. So I'll actually, when I'm doing this on patients, I'll put a little Tegaderm over the eye and then put a lot of gel. I think it's easier that way. That way you can just take the Tegaderm off when you're done and not have to clean out ultrasound gel from the eyeball. But once you got it set up, then you just put your linear probe directly over the eye. You don't want to put a lot of pressure down. You just want to basically sit right on top and then have the patient themselves essentially move their eye throughout the range of their extraocular motion. And what you're looking for is this obviously big eyeball there in the middle. It should, in normal cases, be completely anechoic in the middle. You shouldn't see what we're seeing here, which is a little snake-like structure that kind of is throughout the entire eyeball. And what we're looking at is the retina appears to have detached from the back of the eye.
Yeah, so this is a classic appearance of a retinal detachment. So we can tell that it's a retinal detachment versus a vitreous detachment. They can look similar, but a retinal detachment is going to stay anchored to the optic nerve because it's got tissue here where it will anchor. So a lot of times you'll see this V shape, especially if this is basically a complete detachment, where the retina is just floating here, where it usually should be here. It's now over here, but it does have an anchor point here in the posterior part of the globe, and then detaches again. So this is a pretty severe retinal detachment, which probably could have guessed based on his visual acuity being just light perception. We'll look through a little bit more and look at his left eye as well, but when you're classifying a retinal detachment, the ophthalmologists care if this is a macula-on or a macula-off detachment. So macula-on meaning that the macula is still intact, and macula-off means that the macula is basically lifted off as part of the retinal detachment. So first off, what is the macula?
Yeah, so the macula is the area of the retina that is adjacent to the optic nerve and is responsible for your central vision, so the majority of what we measure when we're doing visual acuity and things. So it's super important for this presentation, of course.
Right. So the macula is basically your highest concentration of the photoreceptor cells. It's your central vision. So as the light comes in through the eye, it just doesn't get refracted by the lens at all. It basically goes straight back to the back of the eye where the macula is. And the macula is adjacent to the optic nerve, which is this hypoechoic area here that you mentioned, and is just temporal to the optic nerve as well. So ophthalmologists speak in temporal versus nasal, which is basically equates to lateral versus medial. So temporal near the patient's temple, or nasal towards their nose. So the macula is probably right around here. So is this a mac on or mac off?
Mac off.
Yeah. So And that's explaining why his visual acuity is so poor, right? Because his central vision is essentially gone. Remember, your acuity in your peripheral vision, which is the retina responsible for your peripheral vision is actually over here, is fairly low. Like if you look out the side of your eye, you can see things and you can see motion, but you can't read out of your peripheral vision, right? So the visual acuity there is pretty low. So he also had decreased visual acuity in the left eye. So it was 20/100. So we'll scan through the left eye, and this is what it should look like mostly, right?
Yes.
So we see the anterior chamber here. This is the iris and the cornea here. So this is all the anterior chamber. This is the lens, this hyperechoic lens here. And the retina should look nice and smooth back here, right? So that's a very stark contrast to the right eye that we saw. So we're going to just look through, and there's maybe some subtle abnormalities here as well. I don't know if you can tell here. There's some hyperechoic thing right here in the peripheral retina, which ultimately I think was diagnosed as a retinal tear as well of the left eye. So of course, when you see this, you got to call ophthalmology right away. Say I have retinal detachment, and they had a full dilated fundoscopic exam and confirmed that there was a macula-off retinal detachment of the right eye, but there was actually a retinal tear of the left eye as well. So surprisingly, or maybe not surprisingly after you learn this, but he got a laser of the eye, but it was actually the left eye that they lasered, the one that didn't look terrible like this. And the reason why is that they're trying to prevent a retinal tear from progressing to a retinal detachment, right? It's because you're trying to preserve any remaining vision. With this retinal detachment, unfortunately, the damage is mostly already done, that eventually they do surgery, but it's not with a macula-off. Retinal detachment is not quite as urgent. That being said, if you do have a macula-on detachment that's not as bad as this, where only part of the peripheral retina is ripped off, that's more of a surgical emergency for an ophthalmologist, because they don't want it to propagate and then involve your central vision. But once the central vision's involved, it's mostly irreversible, even though they still do approximate it. So he did have retinal detachment surgery 1 week later. Just the important learning point there is I had to identify a retinal detachment and differentiate macula-on versus macula-off for an ophthalmologist. Sierra, we're all done with those cases. Thanks so much for going through them with me. Can you just leave the viewers with maybe just one pearl you took away for each patient?
Thanks, Watson. We had a great group of cases. The first case was that splenic injury after lacrosse. Remember, in any unstable patient concerning for hemorrhagic shock, put the probe on as early as possible to get a fast. That'll help you triage an unstable patient for the OR or not. And remember, if you have a positive fast, immediately call the surgical team. No need to get a CT and delay care. Case 2 is that ulnar artery pseudoaneurysm after the cath. Remember that if you see with your color flow a yin-yang sign with a little neck attached to the ulnar artery, be concerned for a pseudoaneurysm, which is an indication to call vascular surgery. Case 3 was that first trimester twin pregnancy. In early pregnancy, remember to get your crown rump lengths and the label twin A versus twin B with who is closest to the cervix. Low threshold to get a transvaginal ultrasound, and remember that you're going to have really high beta-HCG levels concerning from worsening nausea and vomiting. Case 4 was that acute decompensated heart failure. When you're looking at the IVC, just remember it's distended, and if you see some swirling within there, be concerned that there's high pressures in the right side of the heart. Case 5 was the macula-off retinal detachment. For us ER physicians, ocular POCUS is a pretty quick and easy tool rather than a fundoscopic exam, and it can reliably identify retinal detachments and help us better communicate with ophthalmologists regarding macula-on and macula-off.
All right, awesome, Sierra. So let's get in now to the listener Q&A section. We have a recorded question here from Dr. Gioliti, who is one of our resident physicians. Let's take a listen.
Hey, Dr. Watson, this is John. I have been struggling getting images of the aorta super clear. I'm wondering if it's an issue with my positioning or bowel gas, but if you have any recommendations for getting clear shots of the aorta, I would appreciate that.
All right, Sierra, I heard that you had a really great aorta case recently, so I know that you're an expert in aorta ultrasonography. But before we get into your case, can you help us out and help answer John's question here? And let's talk about the basics of aorta ultrasound.
Sure. So the normal aortic ultrasound consists of two major views, longitudinal and transverse. Be sure to get clips and stills in both planes, as well as measurements in the suprarenal aorta and infrarenal aorta. To start, grab your curvilinear probe. Make sure that the probe marker is always to the patient's right. Generally, I usually start in the transverse orientation because it's just the easiest to find the aorta. Start as high up as you can when you get onto the patient's abdomen and look for the deepest structure where your aorta will be located, which is right near the vertebrae. That's your spine sign. Super hyperechoic area, and then the anechoic circular structure right above that should be your aorta. Sometimes bowel gas can inhibit your ultrasound imaging, so sometimes just some firm, steady pressure downward can, if the patient will tolerate it, help clear some of that bowel gas. Once you have your transverse view of the aorta, again, make sure you get clips all along it in the longitudinal and transverse views. And then in the transverse view, get your most proximal suprarenal measurement and then scan down to where you see it bifurcate. And then just above that bifurcation, you can measure your infrarenal aorta. Be sure to always measure outer to outer, that way you don't miss any aneurysms or intramural hematomas. And then in order to get your longitudinal views, try to get your transverse aorta in the center of your screen and twist slowly so that it becomes that nice linear view. You can look for flaps and things like this in this view.
Great. So you mentioned that you're going to take a still image of your suprarenal and your infrarenal aorta. So what sort of normal measurements should we be looking for?
Great question. So your normal aortic diameter is about 3 centimeters or less. And as you go from suprarenal to infrarenal, you want it to get smaller. Anything greater than 5.5, consider consulting with your vascular surgeon to set up for emergent versus urgent repair.
Great. Yeah. I always just remember that the aorta should taper, right? As the aorta is going down, it's shooting off blood to the bowel and the kidneys and things like that, all the abdominal organs. So as you get down to the bifurcation into the iliacs, it should definitely be smaller. So what else can we screen for, though, on abdominal ultrasound for aorta?
So aside from the aneurysms, we can look for flaps within the aorta concerning for dissection. And it's not super sensitive. It's really a rule-in test. You still might need to get your CTA imaging to diagnose these pathologies.
Okay, great. Now that we've discussed the normal, let's talk about your case. So take us through the case from the beginning.
Absolutely. It was a great learning case to have actually in residency in a community setting. I was about 30 minutes into my overnight shift when we got a call over the radio from EMS with a hypotensive man coming in with flank pain, and EMS unfortunately unable to get IV access.
Yeah, and this is one of the community EDs as well without much surgical backup. So did you really have aortic pathology on your differential when you first came in?
I mean, absolutely. I was between, on the pre-arrival, maybe a kidney stone, but the hypotension really was concerning for aortic pathology.
So when you put your probe down, you just started with the aorta?
Yeah, actually. He was pretty tender on my abdominal exam and had what was a large pulsatile mass, which made me reach for the ultrasound immediately. And I'm glad I did, because it showed a large aortic rupture the second I put on the curvilinear probe. The first view I got was the transverse aorta view. You can see it takes up the entirety of the screen almost. And if you look posteriorly, you can see that there is a neck appearing section, which was the tear. I didn't measure it myself, but you can see that the outer to outer measurements would be easiest to obtain in this view.
Right. Yeah, that is definitely very large. So what did you do next?
So I immediately looked to my attending, who was also seeing what I was seeing, and then given the community setting that we were in, our goal was to get a CT scan after stabilization as fast as possible and then get him to his definitive location for management. He was still a hard stick when he got to us and hypotensive, so for IV access and resuscitation, we placed a large central line in the IJ and started blood transfusions. While he was stabilizing for the scanner, we were also talking with the vascular surgery team at our tertiary care site, and basically simultaneously the CT showed what we already knew from ultrasound, which was a 9 centimeter partially ruptured AAA with active extravasation into the abdomen. Thankfully, the vascular surgery team accepted, and he was flown out of the department less than 90 minutes after he got there.
Wow, that's a crazy case. So what was the patient's outcome?
Yeah, it was crazy indeed, especially given that aortic ruptures have really high mortality, up to 90%. He actually had a great outcome. The vascular surgery team took him for an emergent graft, which did unfortunately have to graft over the renal arteries, committing him essentially to lifelong dialysis, but he otherwise had a pretty uncomplicated hospital course and has been doing well on outpatient dialysis.
That's great. So what are your biggest takeaways from the case?
Yeah, so a big learning case for me, like I said, biggest thing for me was to put the probe on as soon as possible. If anything, to look for your standard ER fast, but also getting comfortable with an aortic ultrasound can be really critical in these cases too. So definitely using my POCUS skills as soon as possible.
Yeah, there's definitely another win for POCUS in this case. So thanks again for walking us through that abdominal aorta tutorial and walking us through that case, and appreciate you being on this episode with me.
Anytime. Thanks for having me, Dr. Watson.
That's all for this episode. So remember, if you want to submit a question, you can record your audio question at speakpipe.com/soundcheck, and we'll get it answered here on the podcast. A big thank you to our co-host this month, Dr. Cierra Lewis. For more resources and a full list of episodes, visit mepsano.com or check us out on YouTube at youtube.com/MedStar Emergency Physicians. We'll be back next month with a fresh set of cases, but until then, go out and put these pearls into practice.